Good morning. Today's lecture is on fractures. So let's get started. A fracture is a break in the continuity of a bone. Two main factors contribute to the development of a fracture. Number one, the strength of the force acting against the bone. And number two, the strength of the bone. When the force acting on the bone is greater than the strength of the bone will fracture. The strength of the bone is related to the individual's nutritional status as well as the presence of pathological conditions such as osteoporosis, bone cancer, or Paget's disease. A bone that fractures and undergoes normal healing is called a union. A non-union is a fracture that shows no clinically significant progress towards healing for at least 3 months based on x-rays. A delayed union occurs when the healing process takes significantly longer than expected. Healing time is related to the size of the bone. Fingers and toes take about 3 weeks, whereas femur fractures take about 12 weeks. A malunion occurs when the bone fragments join in a position that is not anatomically correct. Non-unions and malunions may need to be surgically corrected. Young patients are more likely to sustain fractures related to sports injuries, where older patients are at a higher risk related to falls and disease. Bone diseases that decrease the strength of the bone, such as osteoporosis, osteogenesis imperfecta, which is brittle bone disease, and bone cancer increase the patient's risk of a bone fracture. Inadequate intake of vitamin D, calcium, and phosphorus contribute to poor bone strength. Lifestyle habits such as participation in dangerous activities can also increase the risk of a fracture. Fracture prevention begins with education. Children and young adults should be taught the importance of using safety equipment like seat belts, helmets, knee and elbow pads. Practicing good lifestyle habits such as exercising regularly, maintaining a healthy weight, can also increase bone strength and prevent fractures. Creating a safe living environment is key to the prevention of fractures. Older adults should have regular screenings for osteoporosis and risk assessments for falls. Osteoporosis screenings are particularly important for women after menopause because the loss of estrogen during menopause decreases calcium absorption and increases the risk for osteoporosis. For more teaching points to help older adults prevent falls and fractures, see the patient teaching feature in Pearson on page 917. Clinical manifestations of a fracture include a visible fracture on an x-ray, pain, and pain is generally due to an interruption in the continuity of the bone, damage to ligaments, tendons, and other surrounding tissue, and muscle spasms. Depending on the severity of the fracture, other manifestations include a visible deformity if the bone is displaced, swelling from inflammation, and numbness due to nerve damage. Internal or external loss of blood may result in hypovolemic shock or ecchymosis. If the fractured pieces of bone grate against each other, crepitus may be heard. Complications associated with fractures include compartment syndrome, DVTs, fat embolism syndrome, infection, and loss of sensation. Development of complications depends on the type and severity of the fracture and the patient's personal factors. Compartment syndrome occurs when edema and swelling cause increased pressure in a muscle compartment. This leads to decreased blood flow and potential muscle and nerve damage. If the decreased blood flow is allowed to go on and ischemia to the compartment occurs and it continues for a significant amount of time, the muscles and nerves may die. Untreated, it can lead to many complications, including paralysis, amputation, or Volkmann contractures. How do we prevent it? Well, we regularly assess for swelling, pain, discoloration, and we do a good neuro assessment. You use ice and elevation to reduce swelling, and sometimes you delay casting until the swelling is gone. The symptoms are severe pain and tenderness, swelling, paresthesias, pallor, numbness, or paralysis, and absent or decreased pulses, poikithermia, which means coolness in the distal portion of the affected limb. But the patient's report of pain and swelling that are disproportionate to the actual injury is the first telltale sign. Remember, compartment syndrome can result from a fracture, a muscle bruise, a crush injury, or a bandage that is too tight, like a cast. The treatment is, well, if the cast is causing the external pressure, you're going to remove it. However, if it's internal pressure causing the symptoms, then a fasciotomy is done to relieve pressure. So you're the nurse, and you are doing your regular assessments, and you suspect compartment syndrome because the patient is complaining of this severe pain. It's unrelieved by the prescribed analgesics, and the injury isn't in proportion to the amount of pain, and you're suspecting compartment syndrome. You want to apply ice, put that extremity in a neutral position, and notify the healthcare provider immediately. This picture shows a medical professional measuring compartment pressure within a compartment. So they take a very small needle, insert it into the compartment, and it reads a number. Know that greater than 30 indicates increased pressure, and compartment syndrome is diagnosed that way. A DVT occurs when a blood clot or a thrombus forms in one of the deep veins, and it's usually in the leg. Risk factors include decreased blood flow, so immobility from casting and bed rest can decrease blood flow in the limb. So you want to encourage early ambulation, encourage active or passive exercises, and the use of compression stockings or boots. The force that caused the fracture can also injure the vessels. Movement of that fractured bone or during surgical repair of the bone can cause clots to form at the site of the injury. Altered blood coagulation from a massive transfusion or excessive blood loss may cause the body to increase production of platelets and clotting factors, making the person hypercoagulated and at risk for a DVT. Old age, obesity, poor circulation, inactivity, bed rest, smoking, and cancer are also risk factors. So how do we prevent it? Well, first of all, we immobilize the fracture. We stabilize it. Regular exercise and prophylactic anticoagulants, meaning your heparin or your Lovenox, compression stockings, and PCBs. If someone is diagnosed with a DVT, and DVTs are diagnosed with an ultrasound, we treat it with ambulation and compression as tolerated after we start anticoagulation. If that blood clot dislodges from the leg, it can travel to the brain, causing a TIA or a stroke. If it travels to the lungs, it causes a pulmonary embolism, and to the coronary arteries, an MI. A fat embolism. Fat emboli are released from the bone marrow after an injury. They enter the bloodstream and can become trapped in the pulmonary and dermal capillaries. It's usually after a closed long bone or pelvic fracture. In most people, the release of fat after an injury produces no symptoms. However, if a large amount of fat is released, or if there's multiple fractures, a fat embolism may occur. It is rare in children under the age of 10. And why do you think that? Because children don't have a lot of fat still in their bones, marrow. So the signs and symptoms include the respiratory symptoms, and they are usually the first symptoms that appear. It's usually shortness of breath, and if it progresses into respiratory failure. Approximately one half people require mechanical ventilation with a fat embolism. The neurological symptoms are restlessness, confusion, which leads to seizures and coma. This petechiae rash, it's on the upper anterior trunk, the arms, the neck, the buccal mucosa, and the conjunctiva. And it appears spontaneously, but then it disappears within a week. Perth-Scher retinopathy, which is a sudden loss of vision and a mild fever. So how do we treat it? You can treat it prophylactically with corticosteroids and early immobilization, but once it's been diagnosed, the treatment is just supportive. So if they're having respiratory symptoms, we treat it with respiratory measures, put the patient on oxygen. Impaired skin integrity related to an open fracture or surgical correction can put that patient susceptible to an infection. The greater the soft tissue damage, or in an immune compromised patient, the greater risk of infection. So look for the signs of infection, which are warmth, redness, pain, swelling, stiffness, fevers, chills, and purulent damage. Cellulitis is also a sign of infection, as is osteomyelitis, and that's very tough to treat. A gangrene is when the body tissue dies because of lack of oxygen and nutrient-carrying blood, which results in amputation. So again, the treatment for infection is antibiotics according to the infecting agent and proper hygiene. Wash your hands. In emergency care of a patient who has sustained a fracture, you want to immobilize it, right? If there's a break in the skin, you want to prevent infection. If it happens outside of a medical facility, do not try to reset the bone. Apply splints above and below the joint. That reduces mobility and prevents further damage. The primary diagnostic test for a fractured bone is an X-ray. In some cases, they may do a bone scan, an MRI, or a CAT scan. Cervical immobilization, if a spinal fracture is suspected. If it is open and bleeding, you want to stop the bleed and apply pressure. Preventing infection includes sterile dressings to all open wounds, and apply ice to reduce swelling if indicated. Again, any measure that you put into place, you want to assess for pulses, sensation, and movement before and then after the measure that you place. For severe fractures that require direct visualization to repair, the patient will undergo surgery. The two main types of surgical repair for bone fractures are external fixation and internal fixation. With external fixation, metal pins and screws are placed into the bone above and below the fracture. The pins and screws are then attached to a metal bar outside the skin. This is often performed if damage to the soft tissues prevents internal fixation. Internal fixation, or ORIF, open reduction of internal fixation. That is the surgical procedure used to internally repair a bone fracture. During reduction, the bone is placed in correct alignment. Nails, screws, pins, wires, plates, or rods are then inserted into the bone to hold the bone into place. Plates are attached on the outer surface of the bone. Fractures of the long bones are commonly repaired by ORIF. Internal fixation allows shorter hospital stays, earlier return to full function, and fewer instances of non-union and malunion. Complications of reduction include infection, neurovascular or vascular injury, and leg length discrepancy. A cast is a rigid device used to immobilize, support, and protect fractured bones and the surrounding soft tissue. It is applied to a stable fracture after it has been reduced. A cast should cover the joint above and below the fractured bone to prevent bone movement and facilitate healing. A cast is custom made, either from plaster or fiberglass, to exactly fit the injured limb, and it cannot easily be removed by the patient. The nursing care of a patient with a cast includes a good neurovascular assessment. You want to palpate the cast for hot spots, and hot spots indicate infection, so you want to report that. Assess for compartment syndrome, so you ask the patient about pain. Educate the client about cast care, and if you look to Pearson on page 922, you will see a section on care of a cast. Also in your clinical skills book, there is something on cast care also. Splints, they provide less support than a cast, and they're used to stabilize a fresh injury. They can be easily adjusted to accommodate swelling and prevent compartment syndrome. They're readily made with Velcro straps that allow for easy removal. Sometimes traction is used to maintain proper alignment of a bone. It uses weights, pulleys, and ropes and applies opposing force to the fractured bone. It also helps to stretch the muscles that have contracted or are producing muscle spasms. With skin traction, it applies force to the soft tissue using a soft boot that is attached to a weight and pulley system to maintain alignment. We use skin traction to control spasms, maintain alignment, or provide traction if skeletal pins become infected. Skin traction is contraindicated with older adults with frail skin because it may tear the skin, increasing infection risk. Common methods are Bucks, Dunlop, Russell, and Bryant. If you look to Pearson on page 863, there's more information. Skeletal fraction applies force through pins placed in the bone. Pins are inserted with local, spinal, or general anesthesia. The advantage to skeletal is that you can use more weight if needed. The disadvantage is there's an increased risk of infection because you've actually put a pin through the skin, and an increased patient anxiety. As I said, skeletal traction is used when a greater force needs to be applied to the fracture or that skin traction is contraindicated. So nursing considerations. With skin traction, you want to keep the weights off the floor. If they're on the floor, they're ineffective. You want to do a good neurovascular assessment, and you want to assess for skin breakdown. As you can see in this photo, that patient's leg, which is in the boot, is immobile and on a bed. The skin, the heels, actually puts them at risk for skin breakdown on that heel and on the leg. So you want to be specially take care when you do your skin assessment. With skeletal traction, it's pin care because this area surrounding the insertion site of those pins can be infected. You also want to do a good neurovascular assessment again on this. Go back to your Pearson and look at your skin versus skeletal fracture for more information. Skin traction applies force to the soft tissues through a pulley system attached to the bed. Skin cannot tolerate larger weights, so it uses a smaller amount of weight, approximately 5 to 7 pounds, where skeletal uses a larger amount of weight, around 25 pounds. They use it to control muscle spasms, especially if the patient is waiting to go to surgery. They'll put them in skin traction to relieve the spasms, the pain from the muscle spasms. They'll also go to skin traction if the patient started out with skeletal traction and the pins become infected. Types of skin traction are Bucks, Dunlap, Russell, and Bryant. And please review Skill 918, Traction, Skin, and Skeletal Caring for in your Clinical Nursing Skills book. Skeletal traction applies force directly to the bone. It may be used in conjunction with skin traction depending on the location and severity of the fracture. Pins, wires, or screws are surgically implanted. Weights are attached to the implanted hardware in one or more directions to maintain the fracture in correct alignment. This is done under sterile conditions while the patient is under local or general anesthesia. Skeletal pins and other hardware must be cleaned frequently to reduce the risk of infection. If a pin becomes infected, the nurse should notify the patient's physician. The pin may need to be removed and placed elsewhere, or the patient may need to use skin traction. We treat infections with antibiotics. Please look to your Clinical Nursing Skills book under Traction and Cath Care for more information. A patient's age plays a role in the type of fracture the patient is likely to experience. Fractures in infants are difficult to diagnose because of their inability to communicate location or nature of the pain. Some signs of possible bone fractures in infants include inconsolable crying, crying when an area around a broken bone is touched, limited movement of an extremity, swelling of an extremity, or a deformity of an area or extremity. Fractured collarbones are a frequent birth injury, and risk for long bone fractures include cesarean birth, breech birth, and low birth weight. Fractures in toddlers. Although it's not a fracture, nursemaid's elbow is a common childhood injury. This injury occurs when a caregiver pulls a child by the hand with a quick motion. This medical term is called radial head subluxation, where there's a partial separation of the radiocapsular joint. The main symptoms include the child comes in, they hold their arm stiffly, and they don't want to use it. So treatment is reduction of the joint. Prevention of this includes education on avoid swinging children by the hands or pulling by the hands, and encouraging people to pick children up by their arms. Fractures in children. Well, children often experience long bone fractures as a result of sports or play. Spiral fractures are common in children because of the porous nature of their bones, but unexplained midshaft spiral fractures may be an indicator of child abuse. Fractures in adolescence. Athletes, such as long-distance runners or gymnasts, often experience stress fractures related to repetitive force or on specific bones. In addition to repetitive stress, adolescents are likely to sustain stress fractures as a result of imbalanced nutrition. Fractures in adults and older adults. Well, adults may have a lengthened recovery time because their bones have a slower rate of tissue growth. This is especially true for women after menopause and older adults in general. Older adults with osteoporosis have increased risk of hip fractures and are more likely to develop complications such as DVTs and infection. Alterations in mental status increase the risk for injury in adults of all ages. Nursing care for a patient with a fracture starts by an assessment. The assessment of this patient should include obtaining a health history and performing a physical examination. The physical assessment should include an assessment of distal pulses in the injured extremity. You want to check for edema and swelling, check skin color and temperature, check for deformity and range of motion and sensation. The 5P neurovascular assessment should also be conducted, which includes an assessment of pain, pulses, pallor, paresthesias, and paralysis. Managing pain. The nurse should regularly assess the patient for pain and for muscle spasms and swelling, which may increase pain. You want to monitor the effectiveness of the pain medication that has been prescribed. You could provide ice to reduce swelling and use non-pharmacological methods to reduce pain, such as distraction, deep breathing, relaxation, and supporting the extremity above and below the fracture. If you need to move the patient, is important to providing pain control. We want to promote mobility and early ambulation. Early ambulation increases circulation and reduces the risk of complications, especially DVT. If the patient is in traction and their mobility is restricted, you want to help with passive and active range of motion exercises that maintains blood flow and strengthens muscles. You want to reposition the patient every 1 to 2 hours to prevent breakdown. Preventing complications such as infection, skin breakdown, they are all also important to the nursing care of the patient with a fracture.